Dr. Edwin Williams here to answer your questions on facial plastic surgery. As a rhinoplasty specialist, one of the things I'm often asked is, what is a saddle deformity with revision rhinoplasty? So think about the shape of a saddle that kind of goes like this, and that is a saddle deformity. We commonly think of a saddle deformity as a nose where the bridge is way too low, sway back, scooped out. Technically and medically, we call it a dorsal convexity, where the bridge is too low. And by and large, it's the result of someone who's had too much surgery and over-reduced the patient's dorsum or profile, and it looks unpleasant and it looks very operated on. So in order to repair that, we need to do something we call revision surgery. And what are our options? Because I see patients on a very regular basis, and someone told them they could use one option. There are several different options. Ideally, what you want is you want the patient's own cartilage. Now, there is cartilage in the septum of the nose that goes back there, but a lot of times when patients are undergoing a revision surgery, there isn't sufficient septal cartilage left. There are other cartilage sources. One is from the ear, which is an okay source. The problem with the ear cartilage as an isolated source, or the only source, is it sometimes doesn't have the structural integrity. If you think of it, it's just not very stiff. And you might need that, you might need something more. You can use, as other options, irradiated rib, which they call homologous rib. So in other words, a cadaver, the rib is harvested, it's treated, irradiated with x-rays so that all the bacteria and the viruses are killed, and then you can use that. There are advantages and disadvantages of irradiated rib, and then there's what's called autologous rib, which is really my preferred choice for using rib, which means the patient's own rib. Now, there are advantages and disadvantages of rib cartilage. Ideally, we would love to use septum, right? Because it's right in the nose and it's close. But the problem is many patients who come for revision surgery don't have enough septum. So I have to use another source. And it depends on what our goals are. If we need structural integrity, I often don't get enough of it from the ear cartilage. Or if I have to bring the nostril down, I might use a small piece of ear cartilage. And again, we're not talking about deforming the ear. We're doing it in an area of the ear here that does not really get affected. In fact, patients, when they come back a year or so, it's even hard to see where I've harvested. But then there are those patients where I really need a lot more cartilage. And that's when we're talking about using rib cartilage. And again, I have a lot of videos out there on YouTube where you can watch them. They're surgical videos showing how I harvest the rib and showing how we use it in revision rhinoplasty. Now, I had a patient last week say to me, she went for another opinion and they recommended irradiated rib. What are the advantages and disadvantages of irradiated rib, cadaveric rib, versus rib harvested from the patient? Well, naturally, it's one advantage to the patient is you're not having to make an incision here and take that cartilage from them. There is what we call morbidity. There's a downside to that. That's one advantage of irradiated rib. To me, the big disadvantage of irradiated rib is I don't know if it's going to resorb in many, many years. And if you go through all this, and 6 or 7 or 8 years, you lose some of that rib because the body resorbs it, gets rid of it. Well, then to me, it's not worth going through that big procedure. So my first choice is always autologous rib from the patient. What are the disadvantages? It takes more time, and there's that donor site morbidity. But I will tell you the way I harvest the rib. The patients are sore from that area for about a week or so. Sometimes they take pain medicine, sometimes they're not. But by and large, over a period of time, they forget they had it there. So then you're dealing with an incision. What I try to do in a woman is to bring that incision right under her breast and then carry it down to where I need to harvest the rib. So the incision is right up under the breast. So it hides well. So really, to me, the big disadvantage of using someone's own rib is that we have to harvest it. There's some extra time there, a little extra morbidity. I think that there's much greater advantages, and for 25 years I've been harvesting rib and using it because it is the patient's own rib that will grow its own blood supply and will be there forever, basically. I've taken rib out where something has gone wrong, the patient's been hit. There are some people with rib over a period of time, it can move a little, and that's one worry. or what we call warp. Sometimes it can shift a little bit. That's the downside. But given all of the options, which none of them are perfect, to me, the best, the most reliable for the patient is their own tissue, even though it takes a little bit longer. So I hope that answers your questions. There is one other source. People use artificial material, Gore-Tex and such. I'm not a big fan of that because even though there are, it's nice because you don't have to use a radiated rib or the patient's rib, there is about a 5% chance that those patients will reject that material. And for me, that's not worth it. So my first choice is always autologous rib when you need larger amounts. So I wrote a book. You can get this on Amazon. It's Rhinoplasty, everything you need to know about fixing and reshaping your nose. I have a ton of videos, surgical videos on our YouTube channel. You can see that at YouTube/Williams Center. Find my rhinoplasty videos. A lot of, basically any question you might have to have answered about rhinoplasty. And thanks so much for watching. We really appreciate you taking the time. Follow me on Snapchat. A lot of behind the scenes material, shenanigans that we have here at the Williams Center. So thank you so much for watching.